It's my pleasure to invite Professor Usha Singh. We all know Professor Usha Singh. She is president of Oculoplastic Association of India and also heading the Oculoplastic department at prestigious PGI Chandigarh. So we all look forward for Professor Usha Singh's talk on ocular vascular malformation. The third talk, Professor Usha Singh.
Good morning, everybody, respected chairpersons and friends. So I'll be sharing my experience on orbital vascular malformations. First of all, let's clear the confusion of the malformations, tumors, and anomalies. So ocular vascular anomalies, it's an umbrella term. It could be either vascular tumors or vascular malformations. And they constitute about 10 to 12% of all vascular pathologies. Now, coming to the ocular vascular malformations, they are congenital, non-cancerous abnormalities involving the blood vessels in and around the eye. It could be any of these capillaries, veins, arteries, or lymphatic vessels, and they require treatment if they affect the vision. They have structural abnormalities and a normal endothelial activity. And rarely, it could occur in combined forms or rarely isolated forms. Overall, the incidences of malformation is low, but we have been seeing quite a few over the last few years. The clinical spectrum ranges from pinpoint lesions to entire orbit and periorbital involvement, and they pose a challenge to the orbital surgeon. Hence, it becomes important to know the hemodynamic flow, and currently the ISWA classification 2018 is used. So coming to the vascular tumor, here the first line treatment for capillary hemangiomas is oral propranolol, and you can see this is involving the preseptal, orbital, and the temporal areas. And after just on oral propranolol, you can see the regression, and over 6 months it has significantly reduced and the visual axis is clear. Now, so coming to the vascular malformations now. So what is new in malformations? The recent developments in understanding and treating ocular vascular malformations include improved diagnostic imaging, refined classification systems, innovative therapeutic approaches like endovascular embolization and surgical techniques, and novel drugs. So coming to the improved imaging and diagnosis, advancement in imaging techniques have taken place. MRA and MRV, they help in mapping the venous system and have largely replaced the conventional angiography in many cases. Color Doppler, ultrasound, they help in diagnosing and differentiating between various vascular and neoplastic lesions of the orbit. And dynamic maneuvers can be applied. So demonstrating changes in the size of the lesion during dynamic maneuvers like Valsalva is crucial for diagnosing orbital varices, which is a rare subset of venous malformations. Now, the classification of vascular lesions, vascular anomalies, has undergone evolution from 1982 to current. So the classification was ISWA 2014, which was given by Rootman. It was based on the National Course Radiological and Histopathological Characteristics. It underwent expansion and revision in 2018 based on the biological and genetic updates. So this is the one which is being used, and it has divided all the lesions into vasoproliferative and malformations. So the refined classification and nomenclature is currently used. So terminologies such as lymphangioma, orbital varix, and cavernous hemangioma are no longer used. Pure lymphatic malformations, they were previously called lymphangioma of the orbit, which are rare, but venous component coexists in majority. So microcystic and macrocystic types are there. They could be non-distensible or non-compressible. Venous malformations have been again classified into type 1, low flow, which is wrongly termed as cavernous hemangioma. According to the ISWA nomenclature, it is better known as cavernous venous malformation. Type 2, previously known as orbital varices, these are low-flow distensible venous malformations and typically present during the second to third decade. And type 3, that is malformations, they are infiltrative type and they affect the periorbital and intracranial venous system. So they present as enophthalmos at rest and significant proptosis and Valsalva maneuver. So this is the ISWA classification 2008, vasoproliferative vascular malformations. Among the vasoproliferative, you have the benign, locally aggressive, and the malignant. The infantile hemangiomas and congenital hemangiomas, they come under benign. And locally aggressive, you have Kaposi's and angiosarcoma. The vascular malformation, they could be simple, combined, and malformations are major blood vessels and diffuse or syndromic. So among the simple, we have all these pure types, the capillary, the lymphatic, the venous, the arteriovenous, and the AV fistulas. And in combined, you have a lot of combinations of all these structures. Now, coming to the malformation of major blood vessels, there is a difference of opinion on this, which has been put forward in a recent publication by Tawfiq and Dutton, and they have a different opinion. I'll be coming to that. Then you have some of these syndromic malformations. So in 2018, the classification was adopted by other specialties, but orbital surgeons do not strictly adhere to it because of the peculiarities of the orbital vascular anomalies. Because they have these challenging phenotype, diversity and overlapping clinical pictures are there, inconsistent naming and the use of unstable classifications, and they become very difficult to fully understand or understand OVA. So in this publication, 2022, Tawfiq and Dutton, they proposed a simplified version of the ISWA. The two main reasons were that they said that two categories, such as the anomalies or the major named vessels, they should be left out because it does not address major vascular malformations that occur large axial conducting channels in the body, and therefore they are not applicable to the orbit. The second point is that some of these unclassified vascular anomalies, none of these have been reported in the orbital literature so far. So we may see a further update on these classifications in the coming future. Coming to the therapeutic approaches, endovascular embolization, they are used to minimize bleeding and achieve better outcomes, especially in AVMs. Sclerotherapy, it's a non-surgical method of closing down blood or lymph flow. Surgery removal, recommended for AVMs that have bled or are in the area that can be easily reached. And glue-assisted surgical excision is used to minimize bleeding. Intralesional diode laser pre-treatment has also been done to facilitate surgery. So at our center, we have seen we have analyzed 76 cases, though we have seen much more, and we have done interventions in 51 eyes. So among these cases, 34% and 34% is venous malformations and AVMs, and we have LVMs after that. And then a small portion are the other ones. So cavernous venous malformations, they are very they occur in the retrobulbar space or very rarely in the paraxial space as a paraxial proptosis. So you can have diminished vision mass lesion. They are easy to diagnose and they are easy to remove. You can do a cryo extraction, and like this big tumor seen over here, it has a minimal flush after enhancement, and this was easily removed by cryo extraction. Now coming to, we'll see the role of dynamic MRA in this patient. Here is a patient. She's a young girl, 14-year-old girl. She had a bluish mass lesion of 4 years. And it was non-pulsatile and there was no bruit, no trauma, and it was increasing on Valsalva. So a dynamic MRI showed, you can see the flow voids within the lesion. And you can see that with dynamic MRI, which takes a successive, it's a continuous recording of the dynamic process. So you see at 80 seconds, 100 seconds, and 120 seconds, you see there is intense enhancement of the lesion at successive time planes, which was suggestive of cavernous venous malformation. So we went ahead and did a glue-assisted mass excision. However, the histopathology reported as a loose and blood vessels and loose connective tissue, which was diagnostic of capillary hemangioma according to them. That white area which you're seeing is all the glue. And here is the girl. She's post surgery. And so coming to acquired capillary hemangioma, they are true capillary neoplasms of the eyelid and periocular, but very rare. So etiology is unknown. And probably it's related to hormonal changes and increased estrogen levels during puberty and pregnancy. Here is another patient of AVM, and she underwent embolization and recanalization occurred later. So here is a 20-year-old girl. She presented with swelling, headache, tinnitus, 4 years. And she was a known case of AVM of the orbit, and she had undergone embolization of the lesion 4 years ago. And she came with recurrence of symptoms of 1.5 years duration. Her vision was down to 2018. Proptosis of 8 millimeter lateral rectus restriction was there. There was a bluish mass in the superior nasal quadrant, and it was pulsatile. The area just next to it was pulsatile. You can see the corkscrew vessels, and on palpation there was a firm and soft portions both. And this is the area where the firm portion was palpable, and just below it was the pulsatile portion. So AVMs, as we know, they're best managed by preoperative selective angiography with embolization followed by resection of the nidus. So, and in some cases, stereotactic radiosurgery is done. So this patient, you can see when she had first presented, she had dilated arteries, and you can see the superior ophthalmic vein also dilated. You can see the thickened extraocular muscles, proptosis. And you can see the glue cast. That is, they had used tantalum onyx. They had used onyx. Onyx is ethylene polyvinyl alcohol mixed with some tantalum powder to make it radio opaque. And you can see the radio opaque cast in both these. So, and when she came to us, we repeated the angiography, and we can see that there was a recanalization of the fistula with very slow filling of the draining vein, and there was a single inflow and an outflow channel. And this is the cast which is seen in the subcutaneous tissue. So we did a complete workup. We took our time as we were not sure how to go about it. This was our first case to operate an AVM. So she turned out to be thalassemia minor. It was a good thing that we detected that, and we were adequately prepared for it, and we arranged for blood and had a neurosurgery consultation backup. So what we did was, you can see this patient, she was taken up for surgery. What we can see over here, this is the blue.
Ma'am, sorry to interrupt. We have 1 more minute.
Yeah?
1 more minute to go. Yeah.
Okay, I'll just finish. So you can see we ligated the vessel, and it had to be done very carefully because this artery was pulsating on the table. We avoided sharp instruments. And she responded very well. And at 6 months, she was free of all symptoms. And at 8, she has a maximum follow-up of 8 years, and she's symptom-free. And here is another patient who has undergone balloon occlusion for CCF. You can see the balloon placed at the fistula site, and there was immediate resolution of all the signs and symptoms. And he recovered completely. You can see 3 weeks. At 3 weeks, is completely recovered, except that the lateral rectus palsy was there. This is post-traumatic CCF. And slow flow venous malformations. Here is another lady, and we can see that we use glue to excise it, and it turned out to be cavernous venous malformation. And here is a patient who with a bilateral involvement, it's a pure lymphatic malformation, underwent immediate needle aspiration to relieve the RAPD and the stress which was the patient was under. So this is how it is, and he later on underwent neurosurgical excision of this lesion. Here is another patient which turned out to be a varix. You can see that this was infiltrating the LPS on both the sides of the Wittnall's ligament. Here is another patient where we are using glue to excise it. So this was again suggestive of varix. So this is a rare case of Mason's hemangioma, and this is a rare case after trauma, and she had injury to the forehead with significant force, and we aspirated it immediately. She was under pain, so we just aspirated, took out the fluid, she got relieved, but it recurred again. So we used glue assisted surgical excision was done. And this is the histopathology. Basically, it's there was absence of extravascular extension, with 2 to 3 layers of endothelial covering papillary projections. And reactive vascular, it's basically a reactive vascular proliferation after trauma. And there's a single report, first report was reported in 1981, and other treatments have been used in these patients. Coming to the novel treatment, there is an ongoing study exploring novel treatments for recurrent orbital venolymphatic malformations such as sirolimus and rivaroxaban. And this is a single case report of using sirolimus in a 10-year-old child. And you can see there's a 50% reduction in the size of the lesion and decrease in the proptosis. Just half a minute, please. Then there are total 10 patients have been reported, and 3 had complete response, 7 had partial response with sirolimus. So coming to the conclusion, since majority of the vascular malformations of the orbit are rare and they have multifaceted presentation, they are difficult to diagnose and require multidisciplinary approach in managing, is undoubtedly the reason for lack of original studies being reported by orbital surgeons. Moreover, there is a non-availability of instructions for an orbital surgeon on appropriate case selection and stratagems or surgical pointers for getting optimal results and avoidance of complications. The further conclusion is over the past decade, the understanding of these vascular anomalies has undergone a substantial improvement in improving analysis of the clinical histopathological imaging characteristics. Moreover, the management of orbital vascular lesion has been upgraded, and the development of variety of treatment advances which make interventions minimal and surgery safer with newer complications. The last of all, the orbital surgeons are forging ahead to take up these cases to offer relief, as selective cases can be best managed by the orbital surgeon alone, with a pre-operative workup in collaboration with colleagues from other specialities. Thank you.
Thank you, ma'am, for that elaborative talk.